In this video, here's what we'll cover. 3 words we mix up: stress and the body's alarm, anxiety and a future that may not come, trauma and what the nervous system keeps, where they overlap and what actually helps. In the room, I hear 3 words used almost as if they mean the same thing. I've been so anxious this week. I'm just stressed. That was traumatic. And in the moment, they do feel the same. A racing heart, a tight chest, a mind that will not settle. Yet in clinical terms, anxiety, stress, and trauma are 3 quite different things. They have different causes, different courses, and different treatments that actually work. Let me walk you through the differences, so that when you speak to your GP or a psychologist, you can describe what is really happening. In my experience, that is often the first step to getting the right help. Let me start with stress, the oldest of the 3 ideas. In its simplest form, stress is the body and mind responding to a current demand, a deadline, a hard conversation, a school pickup gone sideways. The stress response is not a bug, it is a feature. When your brain sees a challenge, it releases adrenaline and cortisol, sharpening your attention, lifting your heart rate, and giving you energy to act. When the demand passes, the body settles again. That whole cycle, rise, act, recover, is what a healthy stress response looks like. The problem is not stress itself. The problem is when the recovery does not happen. Chronic stress, the kind that never fully switches off, has a name in the research. It is called allostatic load, a term coined by Bruce McEwen in 1998 to describe the cumulative wear and tear on the body from repeated stress. Over months and years, that constant activation is linked to poor sleep, gut trouble, weakened immunity, heart strain, and a higher risk of anxiety and depression. This is why just push through is often bad advice. The body pays the invoice eventually. Signs that stress has tipped from useful into harmful include ongoing sleep problems, muscle tension, a shorter fuse, trouble concentrating, and pulling away from things you enjoy. Anxiety looks similar from the outside: the same tight chest, the same racing heart, the same busy mind, but its inner architecture is different. Where stress is usually about now, anxiety is usually about what might happen next. A person with anxiety is not just responding to a current threat. Their nervous system is scanning for a future one, and often finding it, whether or not it is really there. So anxiety persists even when the situation is safe. The National Study of Mental Health and Wellbeing found that around 30% of Australians will experience an anxiety disorder in their lifetime, making it the most common mental health condition in the country. The common thread is excessive worry that is hard to switch off, a mind that keeps anticipating threat, a body stuck partly on alert, and what we call safety behaviors: checking, seeking reassurance, avoiding. Those behaviors ease anxiety in the short term, but they quietly keep the pattern alive. That last point matters most. Anxiety is not maintained by weakness or wrong thinking. It is maintained by what we do to feel safer. Avoiding the meeting eases the fear now, but teaches the brain the meeting was dangerous. Trauma is the third pattern, and the one most often misunderstood. Trauma is not the event itself. It is the imprint the event leaves in a nervous system that was overwhelmed at the time. Not every hard experience becomes trauma. Around 70% of Australians will go through at least one traumatic event, but only around 12% will develop PTSD. Whether trauma sticks depends on the severity of the event, your history, your biology, and, crucially, the safety and support around you afterwards. PTSD is diagnosed when the response is not resolved within a month, and when the symptoms cluster in 4 ways: intrusions, such as flashbacks and nightmares; avoidance of reminders; negative shifts in thinking and mood, like pervasive shame, guilt, or feeling cut off; and hyperarousal, feeling on edge, jumpy, and unable to sleep. Trauma is neurobiological, not moral. It reflects a nervous system pushed beyond its capacity to cope, one that has learned to stay on alert in case the danger returns. That is why advice like just move on rarely helps. Without help, the system cannot yet file the experience away as past. In real life, These three patterns rarely stay in separate boxes. Chronic stress raises the risk of anxiety and depression. Untreated anxiety can leave a residue that feels trauma-like, and unrecognized trauma is often the reason a person cannot switch off their stress response. This is why the most useful first step is usually not a self-diagnosis, but a careful assessment that asks not only what the symptoms are, but what is driving them. In my practice, that assessment sits at the heart of the first sessions we spend together. The good news is that all three respond to evidence-based treatment. CBT is first line for most anxiety and stress-related patterns. ACT helps when distress is broad and ongoing. And for PTSD, trauma-focused therapies, including trauma-focused CBT, cognitive processing therapy, prolonged exposure, and EMDR, have the strongest evidence. Around 70% of people with PTSD improve significantly with proper treatment. Sleep, movement, and connection matter too, and one umbrella review found exercise can reduce depression and anxiety with effect sizes comparable to some medications. None of these are miracle cures, but done properly, with the right person, they produce real change. If worry, pressure, or a difficult memory is weighing on you, you can read the full guide or book an assessment at our Potentialz Unlimited practice in Bella Vista, using the links below. Before you go, here's a quick recap of what we covered. 3 words we mix up: stress and the body's alarm, anxiety and a future that may not come, trauma and what the nervous system keeps, where they overlap and what actually helps.